if you look at your flow anesthesia, we already showed the nitrous oxide, the isoflurane, and the oxygen in white, how they decay. Now we are superimposing the different systems. So the low flow anesthesia, you are running 1 liter. So you notice there's a very big difference between where you are running and where the gases actually are. They're at 400 and 200. So the only system that actually approximates this is the closed system anesthesia, because remember we said this one tries to calculate how much of each gas has been taken up by the patient per expiratory breath, and then adds that same amount in the inspiratory phase. So it keeps adjusting your vaporizer, the fresh gas flow, and any other carrier gases to try and mimic the exact losses that have been taken up by the patient to replace that. So the closest we can get with anesthesia systems is the minimal flow. Okay, this is the uptake of vital agents in mL per minute. And as you can see, all of them follow an exponential decay curve. So after a period of around 15 to 20 minutes around here, you will notice most of them start to taper off, and then the uptake of these gases really goes down. So most of the anesthesia is utilized in the first 15 to 20 minutes. Then the tissues are saturated with the gas, and then you taper off. So if you look at the different rebreathing systems, I've been mentioning about this, so we're going to look at how each differs. So rebreathing describes a technique in which non-consumed gases contained in exhaled air are partially or completely rerouted back to the patient during the following inspiration. So, and after they have been purified from the CO2, and then they are mixed with a certain amount of fresh gas. So we have the semi-open. Here, your fresh gas flow is way greater than the minute ventilation for the patient. The semi-closed, your fresh flow is less than the minute ventilation, but still greater than what the patient is uptaking. Okay. Then you have the closed, where your flow is equal to the uptake. So what is the catch when you're using this low flow? So if you are running a fresh gas flow of 5 liters and you set your vaporizer at 1%, we are giving the patient, by that formula, 50 mL per minute. So if that is you want to maintain that level of anesthesia to the patient. So where would your vaporizer setting be if you use the fresh gas flow of 1 liter? So by the same equation, we notice that we come to 0.05, which comes to 5%. Now, I know some of you may open your eyes wide at this moment when you say you want to open the vaporizer at 5%, because it is not something we do very often. But you are not, the mathematics has to match. So we are looking at the bioavailability of the gas. So if you are to put it at 3%, you are not giving the patient what you're supposed to be giving them, okay? So let's look at the technical aspects of this. So in low flow anesthesia, there are a few technical requirements. Typically, they are rather generic and more or less independent of the anesthesia machine. So there are certain things that you need. So you need a circle rebreathing system with CO2 absorption. You need accurate flow meters for adjustment of fresh gas flow below 1 liter. Now, this is something you have to check by yourself. How low can your flow meters actually give? The ones which are not digital are very hard to measure, because most times you notice you jump from this to 1 liter. You can't really give like 850. They are very difficult. If you have the digital flow meters, it's quite easy to do this. You need a gas-tight breathing system. If your machine can do self-test, leak test, you should only accept 150 mL at 30 centimeters. So you look at something like your bellows. If they're not rising up to the top of the chamber, this indicates that your breathing system may have a leak. Then look at other alarms like low pressure, spirometry loops. All these can show you that is a leak. The breathing system should have a minimum internal volume and a minimum number of components. So try to minimize the clutter around. So you must have continuous gas monitoring. There is no way you're going to run low flow anesthesia if you don't have this. It's going to be very hard for you to know how much you're actually delivering to the patient and how much is the patient getting. So what are the monitoring requirements for low flow anesthesia? So you need the lower alarm for the inspiratory oxygen concentration should be set between 28 and 30. I know most times we set it at around quite lower than that, but in this case, we are really worried about giving hypoxic mixtures with these low flows. So 30% should be a good limit. Continuous monitoring of sufficient gas filling of the breathing circuit. And you can look at your peak pressures or minute volume. If you notice your minute volume is dropping, then chances are you're having a leak or you are not having sufficient gas filling your breathing circuit. And also, as you start, you notice your peak pressures, then you set your disconnection alarm 5 millimeters or much below the peak pressures. So remember, we shall look at something called time constant, and we'll explain why you need to catch these very, very early when they go. So the threshold for minute volume should be set at a value of 0.5 liters per minute below the desired minute volume setting. And this is all still to protect the patient from either not receiving fresh gas or getting hypoxic mixtures. Mandatory monitoring of the anesthetic agent, both inspiratory and expiratory, so that you know what you're giving. So time constants basically describe the time in which the setting changes at the gas dosing unit lead to corresponding changes at the gas consumption composition in the breathing system. So just imagine, let's say the patient is a bit light and you turn your vaporizer, say, from 1.5 to maybe 2.5. So the time constant is the time it will take for the patient to get that change effected in them. Now, if you have a smaller saturating volume in the circuit and you are running a larger fresh gas volume through that circuit, then of course the time constant is going to be short because the change that you made will be effected quickly. However, if you are running a low flows through this circuit, it is going to take quite a bit of time before whatever you've changed at the vaporizer is effected in the patient. Okay, and this has to be in your mind whenever you're running low flow anesthesia. So basically that is it. So if you look at this, in simple terms, just volume overflow, and you notice it's an inverse of the time, 1/minute. So this curve shows you the time constant. So after 1 minute, only 63% of whatever you've effected will be in. Then after 2 minutes, 86. So roughly around after 3 minutes is when you can get 95% of the effect that you changed. Now, to go back to this, remember that this does not only act on maybe deepening, but also when you are reversing your patient. So if you are switching off your gas, remember, if this is almost a closed system, the patient is going to be rebreathing this same isoflurane, okay? Whatever they breathe out, the expired volume is, the expired concentration is going to be the same after you've switched off. So they're going to keep resaturating this. So it's going to take a while for this now to drop back to zero, unlike when you are using high flows where it's diluted and washed out. So deepening and also awakening. So you find it when you're running low flow anesthesia, you may have to switch off your patients from the vaporizer quite much earlier than when you are running normal. What are the advantages of running this? We already talked about some of them, but let's look at one, the quality of patient care. Normally, when you are running anesthetic gases with high flows, these are usually dry and cold, okay? So reducing the fresh gas flow makes the gases saturating in the circuit more humid and warmer. How this happens is, with low flow, the gases repeatedly saturate through the CO2 absorber, and we know that equation is an exothermic equation. So a lot of heat is generated through the chemical absorption of CO2. So the breathing of warm and humid gases is beneficial for the patient because they help maintain body heat. They prevent postoperative shivering and airway and bronchial drying during ETT use. So technically, when you put an ETT, you are bypassing a lot of the upper airways which humidify. So you are finding that these have been shifted. Remember, these humidifying effects end around the 5th terminal branches. But now with the ETT, you bypass all of these. So someone was actually proposing that we should be looking at the LMA and the IGL a bit differently, because remember they're delivering these gases almost at the start of the trachea. So you don't have that bypass effect. So maybe we should be reconsidering the LMA. Let's look at the economic benefits. So over anesthetic gases are wasted when flows of 5 liters per minute are used. Basically, you are just venting everything out. This not only wastes, but also most of your colleagues may leave when they are a bit saturated with some gas. Okay. Several studies also prove that the use of low flow and minimal flow anesthesia techniques can dramatically reduce the annual cost of volatile anesthetics. So that is very clear. Environmental benefits, we've already talked about contamination of the environment, high flow anesthesia results pollution, especially with the halogenated ones and also the chlorinated ones like nitrous. So, and nitrous is now the leading green gas effect generated by the anesthesia guys. So, desflurane and sevoflurane contain no chlorine and appear to have no or minimal greenhouse effect at this moment. There's less danger of battle trauma. Of course, you are running very low pressures in the system. So volume trauma is very, but then there are also disadvantages. One, limitation of currently used vaporizers. As we said, the modern vaporizers are not so different from the old one. However, these vaporizers are designed for use with high flows. If you remember the diagram of the plenum vaporizers, where you have some of the gases shunted away, then some is shunted into the chamber and then flows over the gas, and then the volatile anesthetic mixes with that, and then the whole thing comes back and then is mixed with the patient. So the use of low flow anesthesia makes these characteristics unnecessary, but also introduces the problem of delivering an adequate quantity of volatile the breathing system. So you are not really sure if I'm running only 250 mils per minute through this vaporizer, is it really picking up enough volatile agent to be delivered to my patient? So a lot of people are skeptical about the patient. And this is where having a gas analyzer comes in very handy, because it can help you see exactly what you are delivering to your patient. There's also a risk of accumulation of unwanted gases into the breathing system. So of course, if you put little gas into the breathing system, little or none will come out. As a result of this failure to flush out gases, the gases introduced which are not taken up by the patient or absorbed chemically will tend to accumulate. So such gases may be exhaled by the patient and then become a contaminant of the medical gases, or result from a reaction with the chemical agents used for CO2 absorption. I think some people remember about substance A, something like that. Now, what are some of the substances exhaled by the patient? So if this guy is intoxicated and they're having alcohol, they're going to be breathing out alcohol. Acetone for our diabetics, carbon monoxide, and methane. So this automatically contraindicates this in patients who are intoxicated, patients with uncompensated diabetic states, or those who are suffering from CO2 intoxication, because you will just be recycling all these into the patient and they could have a lot of effects. So with this, you need more attention, okay? And this is with a nearly closed system anesthesia. Fresh gas flow into the system must be kept in balance with uptake. So you have to keep adjusting your vaporizer. I know some of us like to put our 1 or 1.5%, switch to autopilot. If you're using low flow anesthesia, you have to keep, because the patient can wake up anytime. So you have to keep adjusting to make sure that your patient still is under the required mark that the patient is supposed to receive. Inability to quickly alter the inspired concentration. We mentioned this when I was explaining the time constants, that it's going to take a bit longer for you to effect whatever you've changed at your vaporizer to show up as an effect in the patient. So in some instances, if you are stuck, you may increase the flow for a short while, and then you let the effect set in, then you go. There's a danger of hypercarbia, and this can result from one, exhausted absorbent. So you have to, either your technician has to be very observant of this to make sure that the agent is not exhausted. If you have incompetent unidirectional valves, all this can lead to CO2 being, instead of all of it being absorbed, some of it is vented back into the patient, which is not good. Or the absorber being left in the bypass position, which will be greater when low flows are used. So you have to watch out for all these. You mentioned compound A. Some people have a fear that when you use prolonged sevoflurane, you can have a risk of this. However, this is not and has not been shown to be associated with any clinical manifestation. Even when such techniques are applied to patients with pre-existing biochemical REN abnormalities. Furthermore, if it occurs, so most of it is not really a problem, and the recommendation has been revised in 1990 such that even flow rates of 1 liter per minute are acceptable, but should not exceed 2 minimum alveolar concentration hours. So the risk is there. So if you are running it with sevoflurane, try not to exceed anesthetics over 2 hours if you are running that. So there are some specific safety features of anesthesia techniques with reduced flow. So your equipment maintenance has to be up to date because you don't want any problems with calibration. You are getting wrong values. So because this can be very detrimental to the patient. The long-time constant, like we said, sometimes the good is embedded in the bad. Improved knowledge of the theory and practice of inhalation anesthesia, like we've said. If you're using SIVO, try to avoid going over 2 hours if you're running the low flows. So just to summarize, there are some safety concerns: hypoxia, gas volume deficiency, missed dosage of volatile, reduced contractility, and then exhaustion of the absorbent. So how do we actually do it practically? You know, there's talking about it and all that, but how do you really do it? So like someone says, for anesthesia, boring that work is a good that work. You never want to, when you hear the anesthetist saying, I had an interesting day, then you just know something happened. So you need to be able to adjust the fresh gas flows at different phases of low anesthesia. So I'm not going to talk about the quantitative anesthesia because very few of us have the care station or the ZUS. Okay, but if you do, then you can skip this part. So pre-medication, pre-oxygenation, and induction of sleep are performed according to the usual practice. So that one does not change. Concerning adjustment of fresh gas flow, we have 3 phases: the initial high flow, the low flow. So this is where now we'll go into details about this. So the initial high flow phase, we all know that you have that which starts at the beginning of anesthesia. You run high flows of fresh gas of 4 to 6 liters per minute. And this is just to wash out the nitrogen from the patient's body. Yes, you pre-oxygenated, but then you continue this, okay? So initial high flows facilitate the filling of the breathing system with the desired gas composition, which in turn influences patient uptake and distribution of the anesthetic agents. So remember the formulas we shared in the beginning. Now all these come. So the patient takes, after all, what he or she needs, provided the provider is providing enough. So if you're not giving them enough, then they will not take what they need. So this is a pictogram to show you what pre-oxygenation does. So this is where pre-oxygenation will start: 0 minutes, go up. And as you increase the oxygen concentration in the body, the nitrogen is going to drop. Then at 3 minutes, we can now start including in our nitrous oxide. And these levels will build up in the system, and then they will go down after the body has taken up what it can, okay? So you can see here, you start at 5 liters, then you drop to 1.4 oxygen flow, okay? Nitrous now 3 liters per minute. So this is now your settings at 3 minutes when you're connecting the patient to anesthesia. So the washing of the different anesthetic agents, exponential curve still. So most of the agents are, the high uptake is within the first 3 minutes, okay? And then they all level off. And if you notice here, it shows you the different concentration. Halothane 1.5, isoflurane 1.5. These are the usual Mach 95s where the patient is non-responsive. Sevoflurane will do 2.5, desflurane you can go to 8. So the initial high flow, just summarize, sufficient denitrogenation. You use this chance to do the rapid washing of the desired gas composition into the breathing system, also to fill it up before you reduce, because remember we said your system has to be compact without any leak, so this helps to fill up the whole circuits. Then establishing of the desired anesthetic concentration by looking at your expired anesthetic agent. So your target is 0.8 times the mark that you want. So, and also to avoid gas volume deficiency. Then we move to the low flow phase. This is now where you are going to be in your cruising phase. So after the initial high flow phase of 5 to 15 minutes, or when the target gas concentration has been achieved, then you can start to reduce the fresh gas flow to the desired low level. So the lower the fresh gas flow, the greater the difference between the vaporizer setting and the inspired concentration of the anesthetic agent in the breathing circuit. We've already talked about this. So with low flow, the time to reach the desired concentration in the expiratory gas will be prolonged because of the time constants. Hence, monitoring of oxygen and anesthetic agents is mandatory and necessary when you are running low flow anesthesia. Now, there are 3 options you have. You can use oxygen as a carrier gas. You can use oxygen in nitrous. You can use oxygen plus medical air. So we're going to look at each and see what are the advantages and disadvantages about it. So high oxygen concentration have a lot of advantages. We all know we like oxygen, but it increases patient safety. It also reduces the incidence of postoperative wound infection and the frequency of nausea and vomiting. Although some still debate about the nausea and vomiting. So for most healthy patients, a limited period of ventilation of up to 6 to 8 hours with high oxygen concentration has been shown to have no significant disadvantage. So the use of recruitment maneuvers and positive end expiratory pressure serve to inhibit the atelectasis formation. We shall see this a bit later on. And also the increased likelihood of atelectasis at high oxygen concentration tensions as compared to ventilation at lower oxygen concentration. So you may ask yourself, how does oxygen lead to atelectasis? Now, remember, if you're running high oxygen concentration, the pressures are going to be high. So most of this oxygen, because of the diffusion gradient, is going to diffuse out of the alveoli into the capillaries. And because the difference between the partial pressures of the oxygen in the blood and this one is too high, the oxygen diffuses rapidly out of this, leading to the alveoli to collapse, and that's what causes the atelectasis. So you want to have as close to compatibility of the oxygen partial pressures in the blood to the ones in the alveoli to avoid all that. And that's why I said, if you are to do this, then you have to use recruitment maneuvers if you have been using pure oxygen, and also use a PEEP to inhibit that atelectasis from happening. Contraindications to high oxygen flow. So patients with increased bronchial secretions, like we said, the bronchioles may become clogged and consecutively cut off from ventilation. Because if there's some fluid and then the oxygen diffuses out, then all of a sudden you have a collapsed alveoli with just secretions in them, which becomes even harder to open up because of the high surface tension. So a decreased tolerance to high oxygen concentration can also be assumed for patients with acid aspiration. And this is because of the same issues happening. So acid aspiration with exposure to 100% oxygen for as little as 2 hours can lead to large increases in protein leakage across the alveolar capillary border. And then still, this is also going to cause the alveoli to collapse. Severe inflammatory alterations, and then also premature neonates. I think all of us are very familiar with neonates and giving them 100% oxygen. Besides damaging the retina, it can also cause a lot of other issues. So patients undergoing chemotherapy with bleomycin and mitomycin This is because someone noticed that the patients developed pulmonary fibrosis when they were given oxygen exceeding 70%. So they advocated for reduction in that. Laser surgery, of course, you don't want to be using 100% or higher FiO2s when you're doing laser surgery. Now let's look at oxygen and medical air as a carrier gas. So if the anesthesia machine is equipped with a gas dosing system designed for use with minimal flow anesthesia, you can adjust the composition of the carrier gas mixture to achieve the desired oxygen concentration in the breathing circuit. We call economical anesthesia. One, you are not utilizing out of your oxygen, using medical air as your other agent. Remember, medical air is inert, okay? So it is not going to contaminate your environment. So if the system does not allow low levels of gas flow for medical air, the anesthetist must then decide whether he or she is willing to do without the economic advantages of low or minimal flow anesthesia and instead use low inspiratory oxygen concentration during anesthesia. So you choose whether you want to be economical or you want to pollute the environment by using nitrous oxide. So let's look at low flow anesthesia using oxygen nitrous carrier gas. So the induction of the anesthesia is still the same. There's nothing that changes. But with the connection of the patient to the anesthesia machine, you have to run an initial phase of the high fresh gas flow for around 6 to 8 minutes. Okay. If you remember the picture I showed you, which shows denitrogenation, oxygen building up, and then nitrous coming in and building. So it takes a bit of time. So after 6 to 8 minutes, your oxygen and nitrous oxide levels reach 30% oxygen and 65% nitrous respectively. Now, if you're going to use isoflurane, you normally set the vaporizer at around 1.5, efflurane 2.5, and desflurane around 4 to 6%. These are designed to give you your Mach 95, where the patients will not be responding to that, to surgical stimuli. So after 6 to 8 minutes, an expiratory concentration responding to 0.8 of the Mach of the respective anesthetic agent is attained. Agent. Now, once you achieve that, then now you can start reducing. So around after 10 minutes of running your nitrous and your oxygen, then you reduce your flows to 1 liter per mil, and you can start your low flow anesthesia. So because you are running nitrous, and remember we said there's a risk of hypercarbia and hypoxia with low flow. So when you are running oxygen, we said you can set your FiO2 between 28 to 30 for the, but here with nitrous oxide, you want to increase your FiO2 to around 50%, just in case there is any disconnection or there is a leak or something. You're having at least 50% oxygen, which can help you offset all these hypoxic effects. You don't want to be running 30% where the patient can suffer deleterious effects from hypoxia. So flow reduction also decreases the amount of anesthetic agent because of the time effects. So if the initially selected anesthetic agent concentration, you want to target 0.8 times your Mach, then you must adjust, especially like for isoflurane, you must go to about 3%. But for desflurane, you're already running 6 to 8%, so no changes are necessary. So usually for ISO and CIVO that you need to make changes, you increase your vaporizer settings, okay? From the 1.5, 2.5, then you go to around 3.0. This is just to compensate for the decrease in the amount of anesthetic agent. Now, before reducing the fresh gas flow rates to even lower rates, i.e. the minimum flow, which is 0.5, then the initial phase should be extended to 15 minutes. So the longer you want to run the lower flows, then the longer you have to do with the higher fresh gas flows, okay? Because you want this patient to really be saturated with the agent. You want your oxygen and whatever carrier agent to reach that plateau phase before you initiate your low flows. And if you are dealing with really large patients, you can even extend this initial first stage of the high flows to 20 minutes, because it will take time to get blood gas saturation and also fat and agent saturation. So because the rebreathing fraction is increased compared with low flow anesthesia, oxygen concentration should be increased to 60%. Okay, you notice 1 liter, you're going to run 50%. If you go to 0.5, you have to go above to 60%, with 50 being the absolute minimum if you're going to run minimal flow anesthesia. So unexpected agent concentration of 0.8 of the mark can only be maintained if the fresh gas concentration of isoflurane is now increased to 2.5, CIVO goes to 3.5, and desflurane is increased 1% above the initial setting. Remember, we said initially you may start around 6 to 8. Now you have to do 1% above, unless you're already at the maximum, then you leave it there. Okay. So this is a diagram to show you what we've been talking about. So what you want is to have the patient at this concentration here, the expired isoflurane concentration. So you notice this is where we're going to start, 4.5 liters. Okay. You notice we are not starting at 0 because we have to pre-oxygenate and also around 3 minutes, you kick in, you start your high flow phase, 4.5 liters with isoflurane of 1.5. Then at around 6 to 8 minutes, so now you decide if you're going to run the usual one, which is your 2 liters or above, then you want to start at 1.5, and after the patient has settled and flattened off, you can go to 1.3. So you notice the lower the flow, the higher the vaporizer setting, because you have to compensate for the reduced agent and the time constants. So 1 liter, you go to 2, and then 1.5. Okay. 0.5, the vaporizer settings have to be changed to 2.5 so that you are able to give the same amount of agent as you would if you set it at 1.3 and you're running 2 liters. So from all that explanation and the contamination and others, this is a question I posed for you, my colleagues. Should we still be using nitrous oxide? And that is something both of you have to think about in your heart. So the recovery phase, at the end of the anesthesia high flow, so usually 100% oxygen is the one we use. So you've switched off your nitrous, you've switched off your agent, and you want to facilitate the washout of the anesthetic agent from the patient and also to remove the agent to the scavenging system. But remember what we said about time constants. If you're going to wait for the surgeon to finish and then you say, okay, let me switch off the vaporizer when you've been running low flow, chances are you will spend another 20, 30 minutes in there waiting for the patient to get back up. Okay. So few comments here. So is such a safe and simple procedure that there are no reasons why we shouldn't be using it routinely. So it is still possible to find anesthesia departments where low flow is not used in special situations, especially when you're doing prone, thoracic surgery, or simply not at all because one, people are not aware of the technique, or the training, people have not been trained in them. The most common misconception about it is that it cannot be used in spontaneously breathing patients or with those having an LMA. And we said LMA is actually much better because it doesn't bypass the humidification bits. So we should be starting to adopt this, one for the environment and also for the agents. So thank you very much.
Thank you very much, Hannington. I think now we shall take a couple of questions. There don't seem to be any right now, so maybe I will ask mine. Hannington, are there any particular agents that are ideal for running low flow anesthesia?
So Peter, clarify, you want anesthetic agents or carriers?
Anesthetic agents, besides nitrous. Which one would you pick? Which one is most suited for running low flow?
So I've discussed 3 agents: oxygen alone, oxygen with medical air, and then oxygen with nitrous. So oxygen alone has its own problems. Like we said, we've seen the contraindications. So my favorite would be, I would advise people to be running oxygen with medical air. It seems to be the best, considering that nitrous is a green gas effect, has its own green gas effect, and most times the effect that it would give you in maybe the little bit of anesthesia that it has can be offset by using opioids and all that. So I see no reason why we should still be using nitrous as a carrier gas in this agent, considering its pollutant effects. So for the anesthetic agents, basically you can run low flow with anything from halothane, iso, civo, and desflurane. All you have to do is know what mark you are targeting, and then have your expiratory flow monitor on, so that you know that you are actually delivering that actual concentration to the patient. So you keep adjusting. The lower you go, the higher you find your concentrations running. So that also comes in. Some people say it will, you are wasting, you are using more of the gas, but considering that oxygen tends to run out more than the agents, I see it as an offshoot.
All right. There's a question here from one of the attendees. I think I'll read it out. He or she says, thanks for the presentation. Can you use low flow for patients with lung pathology, like restrictive lung disease? So, and there's another question here. So let me just read the second question, then I'll let you answer. From Ngavonziza Godfrey, what may further affect intraoperative partial pressures of oxygen between increasing oxygen flow or increasing tidal volume? Hannington.
Okay. Thank you. So like we said, if you're having patients with restrictive lung disease, okay, you can still do your normal anesthesia the way you've been doing it. Remember, if you're running low flow, this has no effect on the tidal volumes that you are going to be supplying to the patient. Remember, the initial phase is when you reach equilibrium. So when you reduce the flow, remember, it's not that you vented off the other gases, okay? You are running almost a closed system. So you are just adding a little bit of fresh gas to whatever was expired out by the patient. So you are recycling the same gas. So the tidal volume that you are supplying to this patient will not change. So still you can, if you are doing restrictive and you are running maybe low tidal volumes, the amount of tidal volume that you are supplying to the patient will not change. Okay, it will still be the same. So that one, I don't think there's a limitation for that. Okay, you just have to, for institutions where you don't want high oxygen concentration. So I think that also answers the person who was asking about the tidal volumes and the partial pressures. Okay, if you remember those gas laws, the total partial pressure is going to be a sum of the gases that are constituent in there. So if you are running oxygen alone, then you are going to have the total partial pressure just being composed of oxygen alone. So if now you're having the carrier gas, either nitrous or medical air, then these are going to come in and contribute to the total partial pressure in there. So what you want is to have a semblance of similarity between the partial pressures in the blood and the lung, so that you don't have that rapid movement of oxygen out of the alveoli into the capillaries and into the blood, so that the alveoli collapse on you.
Okay. Thank you, Hannington. We have about 8 minutes for some more questions, if there are any. Please type them out in the Q&A. Okay, looks like everyone seems quite happy with the presentation, Hannington. Yeah,
thank you.
I think probably confused. So I think if there are no questions, if there are no further questions, I think we can close now. Thank you guys for attending. This was organized by the AAU. We will have some more, we'll share with you when the next one will be. Thank you for attending. Thank you, Hannington, for a wonderful presentation. I hope after this, people will be able to run low flow anesthesia.
Yes, and we stop using nitrous.
Yes, and we'll stop using nitrous. There's one question here, I think just before we sign off. There's a question here. Is it important to monitor inspired and expired oxygen concentration if a low flow meter setting is accurate? If
yes.
flow meter setting is accurate, yes.
Yes, it is still very, very important
yes.
for you to know how much and the FiO2 that you're actually giving out to this patient, especially now if you are running, for people who use nitrous, you have to be very careful with the low flows, because like I said, you have to make sure your FiO2 is around 50%, and if you go down to the minimal or the metabolic, then you may have to be running FiO2s of 60%, so that you don't risk causing hypoxia in your patient, because you are running very, very low flows.
Yes, I think it's still even without having even without doing low flow anesthesia, you still need to monitor your oxygen concentration, because you don't know what you're giving unless you have an oxygen monitor. The flow meter just tells you there's a gas flowing and not what gas you're giving. Hannington, one question here. Are you talking about nitrous at induction?
So if you remember the curve that we were drawing, we said you want to denitrogenate with so your induction is going to be the same. You pre-oxygenate with your pure oxygen, get out as much nitrogen as possible. Then you want to start, if you're going to use your nitrous oxide as your carrier agent, which I wouldn't want you to do, you want to start it around 3 after you've connected the patient to your breathing circuit, okay? After your induction, you've intubated and all that. Then you start your nitrous, and then you titrate your FiO2 so that you are, if you're going to run 1 liter, you can go about 30% to, and the other than 65%. If you are going to run 0.5, then you want to aim for between 50 to 60% oxygen. So you titrate your nitrous and the oxygen to give you, to be able to deliver a blended concentration which has an FiO2 of around 60%. I don't know how many people use nitrous to induce. I personally don't use it during induction. Normally, you just want to run to flush out as much nitrogen as possible. Then normally after the patient has been connected, then you switch on your nitrous if you want to use it.
Yeah, I also haven't used it much. The last time I used it, my patient was giggly. and couldn't start the case. Anyhow, if there are no more questions now, I'm about to close this session. And once more, I'd like to thank you, Hannington, and the attendees for giving us your time. I hope this session has been useful. I will now bid you good night.
Thank you very much, everyone.